we get to start the developmental chapters, and that's going to be our very next section. Let me show, let me just kind of go over for you the areas that we're going to cover. This is the whole beginning where we're going to go prenatal newborn health screening, the perinatal period, the infant health, into toddler preschool, school age, and adolescent. This is where our well child visits come in. And so the first one that we want to go into is going to be, we're going to start low with the youngest, and we're going to go into first the perinatal. If I could just have you be sure that when we go through this chapter, and for our listeners, as you go through these chapters, this is a building process. So the perinatal newborn and the infant are going to have a lot of similarities in their assessment. Okay? So I just wanted to point that out to you, but we want to look at them distinctly. Newborn assessment history. I have to tell you how important the prenatal history is to the entire first 3 years of life. Because you're looking for the first 3 years of life, you're looking for the acquisition of milestones. And that may be impeded based on what happened in the perinatal period. So you want to think about detailed history, pre, peri, and postnatal course. You want to think about the prenatal history. What were they exposed to? The mother exposed to maternal health problems, fetal health problems. How does the mother feel about the pregnancy? We also want to know about what? The delivery process. Vaginal, C-section, planned, emergent, induced labor, again, anesthesia, analgesia. You want to think about, too, were there any complications? Placenta previa, abruptio, was there a meconium, either an ileus, or maybe there was some type of aspiration, forceps vacuum. You want to think about the size and the parameters. And just thinking through here, you've got your low birth weight, extremely low birth weight, and we know that the age of viability is considered 24 weeks, but we want to get them to at least what? 34 weeks because of the lung maturity, right? And so we want to think about how important that aspect is. What about gestational age? As it says up here, it's appropriate for gestational age between the 10th and 90th percentile. Large is more than 90th percentile, and what? Small for gestational age is going to be below that 10th percentile. I will tell you, in primary care, we often will give a SGA baby, a small for gestational age baby, up to about 2 years that we can manage in primary care to let them catch up. Remember we did that? Remember earlier I mentioned to you about adjusting for a preemie for 2 years? Well, we also give small for gestational age children at 2 years to catch up. And so it doesn't mean that an SGA baby who may be smaller weight, size, and so forth, you got to rush them off to an endocrinologist, but you give them enough time and nourishment and support through the parent to try and get them to thrive. We also know about the APGAR score. Do you all remember the APGAR score? That's kind of a little score that we use, 5 areas of assessment for a total of 10 points, where you look at the appearance of the neonate, heart rate, grimace, activity, breathing. We score them at 1 in 5 months, and 5 minutes, and it gives a sense of where is this baby in terms of their initial features. Don't you love thinking about how they use all body parts and so forth? But you think about, you know, the things that are going to occur, the hospital course, maternal problems, bleeding, volume problems, anesthesia, breastfeeding, if the mother's depressed, if there's fever and infection. We also want to think about, you know, blood incompatibilities, hyperbilirubinemia, and some physical things like hip dysplasia and murmurs. And I'm going to go, when I go into the physical exam, I'm going to go into some of these aspects with you. Talipes equinovarus is a clubfoot, and of course genetic syndromes. So let's delve into that physical. You know how important it is going to be at each stage to do your parameters, your general, you know, weight, length. It's so easy to just jump to height, but we need length, and these young ones, they cannot, these babies. And head circumference. We're going to talk about when you transition over, how often do you do it, when do you introduce, you know, when can you stop doing head circumference and so forth. We also know that intrauterine growth retardation is a really key component. And let's look at your notes there. Let's take a moment and talk about intrauterine growth retardation. And I also, when I see that term, IUGR, on the exam, they don't use acronyms. Everything is typically written out. Does that make sense to you? So in other words, so that there's no mistake in what the question would be. So when you think about IUGR, and in your notes there for number 3, you have where you have the head circumference, weight, and length. They're all less than the 10th percentile. And this is the one that's symmetric. And usually it suggests either a genetic component or intrauterine infection or inborn error of metabolism. Something has made the baby be just a little smaller. It could be familial also. Then you've got what's called, and that one actually is a little bit less prominent. The one that is more prominent is the one that's asymmetrical, which is going to be what? You got a little extra fetal compromise where it says here that the head circumference, I'm looking at B. Are y'all reading with me? B, head circumference and length within normal limits, but the weight is less than the 10th percentile. And if you look at the potential extrafetal compromise that it could occur, it could be a mother with chronic hypertension or maybe preeclampsia, or a baby has renal disease or congenital heart defect, hemoglobinopathies. Maybe there were multiple gestations. I think about the octomom, right? She had the 8 babies. Or high altitude. Think about I don't know if anybody's ever been to Peru, up in the Andes, up in the mountains and so forth. A lot of those individuals are smaller stature because of higher altitude and so forth. So you have lots of different either physical or environmental influences. We also know LGA is more than 90th percentile, and you'll see there that A is either like maternal diabetes or maybe it's familial or larger mother. There are some conditions like it says here, Beckwith-Wiedemann syndrome. We also hydrops fatalis, but I can tell you pretty much on the exam, for example, for those of you who are studying for the exam, you're not going to be asked anything unusual. And another little sidebar, let me just take a moment to tell you this. I didn't tell you about how many test questions you have, okay? Let's just think about this. Most of you have a 3-hour block to take the exam. If I could recall, ANCC, if you know pediatric people, you can take either ANCC or PNCB. I don't know, but I think the PNCB, unless they've changed it, is 200 questions of which 180 count for your score. So that means 20 of them are being tested psychometrically. ANCC, it's 175, of which 25 are being tested psychometrically. So when I say 25 being tested, they're not part of your score. Does that make sense? And AANP, I believe it's 150, of which 15 are being counted for your score. This information will be on your websites, and it changes from time to time. The reason I tell you this is if you have 3 hours and you have roughly anywhere from 180 to 150 questions, that is plenty of time to, number one, go through the test. I'm a very slow test taker, and I use every single minute of, just because I personally, doesn't mean you have to do it. That's my personal style. I would take the time to go over and make sure I answered it correctly and so forth. Everybody has their own approach. But for that number of questions, for the vastness of the information, they're not going to ask you hydrops fatalis or Beckwith-Wiedemann syndrome. You see what I'm saying? So I want you to put it into perspective. All right? All right. So let me get back on track over here with this. I know I'm going to tell you. It's down at the bottom there. It says Dubowitz-Ballard exam for gestational age. This is an area where, for instance, the posture, I'm going to come back to it and tell you. Let's look at your notes here. When you think about, you've got A and you have B. And if you'll notice there, it says physical maturity, 2 hours of birth, points 2 to 5. And so you're going to look at certain things like skin, lanugo, plantar creases, breast, eye, ears, and genitals. And you remember the genitals are what? Pretty prominent because of maternal hormones. And then the neuromuscular maturity has to be done within 24 hours of birth. Do you all remember having ever had a chance to do one of these? Hopefully you've done aspects of it. It's a form. You may remember it's a form that has all the little features, and you kind of go along and you grade them. and then you come down to the section that has the neuromuscular. And let's just take a look at a couple of the neuromuscular aspects. You know how important posture is. Posture is absolutely key. That's a pink pig, the posture. The posture is important because you want babies to have some flexion, and you want them to have good tone. You don't want a floppy extended baby, right? So as you can think about it, is good flexion is going to be important. Do you remember the term square window? Square window is when the angle between the palm, when you flex the palm towards the forearm, you're looking at that angle there. And when it's achieved, the preemies have a 90-degree angle, whereas a term infant can flex more closely towards what? The forearm. And when you think about scarf sign, I think about this, putting a scarf around my neck. And wherever the line of the elbow is will tell you where the child is. The term infant's elbow will not cross midline, but the preemie will cross midline and be closer to the opposite shoulder. Now, none of these will be looked at in solo. So what you'll do is when you do a Dubowitz, which has physical to be done in 2 hours, within the first 2 hours, because you want to look for those physical features, and the neuromuscular within 24 hours, collectively they get a score. And as you can imagine, the scoring is going to be, as you can see here in your notes, I just want to bring that to your attention. You'll see there that the scoring is low scores indicate immaturity and high scores are either mature to post-mature. So just keeping that in mind. Vital signs, they're not going to really ask you specifically thinking about where is a child with a particular age, but we know that vital signs change quite a bit. Now, if you think about temperature, babies, the younger they are, the less mature they are and able to do what? Regulate their temperature. So they're usually, the thermoregulatory system is a little off. So that a child could have an infection or a fever, but yet have a subnormal temperature. Pulse and respirations can be much higher than this, right? You can get kids that are having a 220. I mean, it depends upon what's going on in terms of their pulse. And blood pressure is inversely proportional to what we see with adults. Oftentimes, the vital signs will be interjected in a scenario question based on a child that's having a fever or an infection or something like that. Let's talk about skin. We could spend 2 weeks just on skin. My goodness, there's so many skin. But typically, we think about pallor, cyanosis, plethora, jaundice, and gray would be a couple of the more common types of skin coloring. And you think about cyanosis. What is it when you have cyanosis in the extremities? Acrocyanosis. Remember that term, acrocyanosis? And then the term plethora. This is an important one. Plethora, a lot of things that go on with the skin, like plethora, is a reflection of either a physiological concern, such as for this one, when you have too many, think about this, plethora, which is a blotchiness to the skin, especially when you kind of blanch it over the abdomen and you got all around it is very ruddy looking. Plethora is associated when you have too many RBCs per fluid volume. And it's a physiological phenomena that starts with a P. Can anybody tell me what that is? Polycythemia. Okay, now what does polycythemia mean to us? If you have too many RBCs per fluid volume, babies with polycythemia who represented in their skin can also have what? Stroke, neurological sequelae associated with it, right? So you want to think about that. Then there's all kinds of skin considerations like milia and miliaria, erythema toxicum, cafe au lait. Let's take a look at some of these, okay, and think about this going through. Let's delve into each one. Milia is pinpoint white papules on the face, prominent on cheeks, nose, chin, and forehead. Often, babies who have milia often have Epstein pearls on their gums. Now, miliaria. Okay, this is prickly heat. Eccrine ducts are affected. They're obstructed. The sweat glands. And all of these are kind of very benign, and they will recede after a time. And can I give you another little sidebar? The sidebar that I want to share with you is do not let any term that you get on the exam intimidate you. Okay? And I tell my friend back here who doesn't feel efficient, I'm looking at my friend back here, I'm looking at you. She's okay. Because you can always figure out a word. So if you know milia, but then you see something that says miliaria, and I can't remember what she said, what you want to think about is it's got an R in there. Something's got to be red. So you're going to pick the choice that has something with redness to it. You see what I'm saying? There's going to be ways that you can pick these words apart if you don't remember. Now, erythema toxicum, most common newborn rash, which is usually appears day 2 to 5 after birth, and blotchy red spots on the skin. And it's very, very common. Parents get very excited about this. Anything that looks unusual with their baby, right? Cafe au lait spots. Now, cafe au lait spots, typically, it's a subtle shade of discoloration, often on the flank, okay, on the trunk area. Typically, we do not see these in newborns. If you see more than 5 in a child, say, under the age of 6, it's highly diagnostic of what? Neurofibromatosis, or what's another term for neurofibromatosis? We're gonna briefly look at that in a few moments when we get, a few moments this afternoon, when we get to neuro. Von Recklinghausen disease. Do y'all remember that term? Okay. So, so again, there's another term for you. Junctional nevus. Junctional nevus is just a good old nevus or mole. If you have many of them, tuberous sclerosis or other kinds of conditions associated with like neurofibromatosis may be associated. As soon as I finish the skin section, we'll take a break, okay? Additional skin variations, Mongolian spots. Mongolian spots, as you can see in your notes here, this is mostly common among populations of color, African American, Mediterranean descent, but 10% of Caucasians can have Mongolian spots. And they can typically last for a while. They can last up to 3 to 5 years. I've had a child even up to 7 years, depending upon, you know, it's the receding, that process. Port wine stain. Port wine stain is another condition. Now, this is a very serious one. You've seen it where a child has an area, it looks like a flat, blanching redness of the skin. You may see it like down one arm, one side of the body. Well, while you may think it's pretty benign, port wine stain is associated, 70% of kids that have it have some type of neuroocular condition, such as what? Glaucoma and seizures. So it's very important that those areas be assessed. Hemangioma, which is a vascular tumor, or what we call like a strawberry mark, and it can be hyperpigmented, and it can, you know, basically after 6 months of age, you'll see strawberry marks usually begin to shrink and fade. Depends upon where it is and whether or not, you know, usually it will take a consult with a dermatologist / plastic surgeon to see whether or not how they would go about maybe removing it if it needed to be. Sometimes they're on the face, the upper trunk area. Okay, let's go ahead and do neurological exam. We touched upon neurological exam earlier when I mentioned posture and tone. And we know level of consciousness is key because babies are often in what? A quiet, alert state, very sensory motor in their learning. Reflexes should be symmetrical, and of course primitive reflexes such as the nervous system development is going to be key. And do you all remember the primitive reflexes? These are some of the examples. If you'll notice, basically in your material that all of them appear at birth, newborn period, but then they begin to disappear. And when they disappear, that means that those nerve pathways are myelinizing. They're going about their development as we expect. We do think about Babinski, for instance. Typically, that's the fanning of the toes. If you were to stroke the bottom of the foot, the fanning of the toes would occur. And so when you think about a child that's starting to walk, that naturally they don't fan out. But when a child has a neurological insult, then you may see that occur again. We also know head and neck. And like I said earlier, babies look like they have no neck. It's like the head is just stuck on top of the shoulders. So you got to get in there and you got to really look around. And the head looks like the largest part of the body. But actually, let me just tell you, if you were to measure the chest and the head, sometimes the chest is an inch, maybe not quite an inch, you know, larger than the head, but it appears that the head is larger. And so you're going to see that occurring. And so when we look at the head as a whole, we're going to think about certain soft tissue swelling in certain areas like a cephalohematoma. I'm going to talk about that in a moment. Bossing, and bossing has to do with when you have, as it says, rickets and prematurity. Microcephaly is a small head. You may have heard the term craniostenosis. Remember that term? Craniostenosis. And think about it. If I didn't talk to you about that and you got that on the test, you could figure that out, couldn't you? Stenotic areas of the cranial bones. It's going to be what happens with craniostenosis as opposed to microcephaly means small head overall. Craniostenosis means certain suture bones close prematurely in one direction. So you may have more of an elongated but yet smaller head. Macrocephaly is a large head, and then you think about too the overriding sutures. Now, when you think about caput versus cephalohematoma, one of them can cross the midline, which is often what? The one that is caput. See how when you think about crossing midline, soft tissue injuries, more of just a swelling that occurs. But cephalohematoma, which means they would probably have a more significant injury, such as a little break in the periosteum, you're going to have blood into that area. It's going to go through all the ecchymotic changes, and it stays on one hemisphere. It doesn't spread like a soft tissue injury. Hair we mentioned earlier. Hair patterns and hair growth that match the race should be uniform. Hairline at the nape of the neck is consistent. We mentioned growth direction. Growth direction is important because hair reflects brain growth. More than one whorl. Does everybody know what a whorl is again? The whorl is the initiation of the hair at the back of the head. Unruly hair. And so when you think about some of the conditions we talked about in genetics, several of those children had hair that was either had uneven lines, seemed to be a little unruly, and they often have some type of a learning disability associated with it. Fontanelles, the largest is the anterior, closing around 18 months. Posterior, maybe closing around 2 to 3 months. It may be or may not be palpable. Common causes of white fontanelles, pink pig. They love this one. I always think about some of the questions they think about. But pink pig is prematurity, IUGR, or small for gestational age, and hypothyroidism. Those would be some of the key ones that you would see with wide fontanelles. Now, eyes. Eyes are very important to evaluate in terms of what you're looking for. The first thing you're looking for is that good old red reflex, right? And that red reflex, usually, depending upon the ethnic background of the child, may be a pinkish red, a red red, an orange red. So you're going to see some variety. And doesn't it take most of y'all a little bit of practice to get used to using an ophthalmoscope and looking for features? That kind of comes with practice. But what you want to think about, red reflex replaced by a black spot means there's no clear pathway, or if there's whitish color like a retinoblastoma. Retinoblastoma is a what? It's a malignant tumor in the eye. Congenital cataracts. When I was in Haiti, that was one of the things that I found that was very interesting. Lots of twins and also lots of congenital cataracts among the children that were Haitian. Bluish appearance such as osteogenesis imperfecta or in the sclera. So you're looking for features. What about, we didn't mention this, but can somebody tell me what the white specks of a child who has Down syndrome, what they're called? Do you remember brush field spots? The specks, the little white specks in the eyes that look like little flecks. Have you ever heard that? That's kind of a classic finding. So again, you're looking for syndromic features and so forth. Now, coloboma. Coloboma is a mild form of where the embryonic fissure defect occurs, and it can be mild, affecting only the iris, all the way to being more serious where it affects the optic nerve. Children with a coloboma, which is just an incomplete fusion of the tract back to the optic disc, occurs. That doesn't mean that they are going to be blind or have any visual problems unless it involves the optic disc. Heterochromia. Okay, let's talk about that term. Chromia means color. Homochromia means same color. So therefore, heterochromia means what? Mixed or different colors, right? So you're going to see either one eye being one color, one being the other, multiple colors in the iris, heterochromia. Cloudy cornea and also a salt and pepper spot. There you are with your breast field spots. So there you go. You got some different features. So the coloboma, and you think about, again, let's just reiterate, it's the defective closure of the embryonic fissure of the eye. Something like that would not necessarily involve any type of visual disturbance unless it involves the optic disc. You're going to look at the ear, nose, throat assessment, ear symmetry, pit skin tags. So you're looking all around the ear. What else would you look at the ear? The placement of the ears. Low-set ears often, which we didn't really talk a lot about low-set ears in the genetics section, but low-set ears is a common finding syndromically with other conditions, particularly with renal problems. And mouth, palate size, and shape, choanal is the narrowing, the blockage of the back of the nasal area present at birth. Microstomia. Stomia means the mouth itself. We often think about this in a baby that has Edwards syndrome. This is trisomy. Earlier we talked about trisomy 21 with what? Downs. Trisomy 18, Edwards syndrome. Babies that have Edwards syndrome, just even though we didn't go into it in detail because we wanted to limit anything that maybe is less common for you, but Edwards syndrome, these babies, don't you think this baby would probably do what? Probably have high-pitched shrill cry, decerebrate, decorticate posturing. Often they're very hard to console. Babies with Edwards syndrome don't often live beyond the first year of life. They have multiple neurological condition that impedes them. Now, cleft lip and cleft palate, believe it or not, is not often assessed on the exam, but we know that cleft lip and cleft palate as a whole can be one or the other or a combination thereof. It can be a variety, and you could think about the nasal passageway, the palate itself, just the lip. These children have to go through a series of surgeries for repair. You're going to be concerned in the newborn period of what? You're going to be concerned about their ability to feed and nurse at the same time and not aspirate. Positioning is going to be important. All the surgical care that's going to go along, and as they get older, they're usually more likely to have more respiratory infections. So those will be considerations. Macroglossia. Now that doesn't look like a real large tongue to me, but macroglossia means large tongue, and again, it's often associated with what? Hypotonia. That's something that we've seen with the Down syndrome baby. Here, Epstein pearls. Epstein pearls are often associated with conditions where you see milia, right? But Epstein pearls is really just a keratinized collection in the gum itself. It will recede over time, no concern there. Natal teeth have no root, so they can also be easily removed so the baby may nurse. And think about head and neck. Now, when you think about under the head and neck, you're going down to the face area, the chin, micronanthia. Think about conditions like Pierre-Robin, Treacher-Collins, and Hallerman-Streiff syndrome. Now, don't freak out when you see these terms because it's like, oh my gosh, we could spend an entire course just going over different genetic conditions. Probably these will not be assessed on a general exam, but we do know there are a lot of these conditions that have facial features like receding chin and so forth. Clavicle fractures, webbed neck and lymph nodes. Really check that neck. Remember I said it looks like the baby's head is what? Plopped right on top of the shoulders? So you have to get in there and look in at the folds of the neck very closely. Fractured clavicle. Think about an x-ray. Do you think you could have x-rays on the exam? Yes. X-rays can be on the exam. They can point to something, ask you a question about it. So you want to be able to observe fractured clavicle, webbed neck. Now, let's think about this, a baby with webbed neck. Turner syndrome. This condition would be something common, Turner syndrome. This is the webbing of the neck is kind of in this area here, around the neck area, and that's the remnant of fluid being reabsorbed. Some other things to think about with this Turner's baby. Let's just take a moment to look at, because remember, it's syndromic. Flat occipital area, misshapen ears. Remember we talked about shield-shaped chest? That means widely spaced nipples. So you see how you're looking for patterns of things, okay? Pulmonary and chest, very important. Now, babies are abdominal breathers, but if they have retraction, stridor, grunting, oh my goodness, that's a baby that can turn on you very quickly in terms of respiratory distress. And it just takes just a second for them to change that quickly. Breast enlargement is for a baby that has a chronic respiratory condition where they're constantly trying to strain, utilize their muscles, their accessory muscles, and so therefore their breast enlargement appears like they're spaced out and they have more tissue on the chest. Cardiovascular, we're going to spend an entire chapter on cardiovascular, but you're looking at capillary refill, your pulses, you're looking at comparing your pressures, upper and lower extremities, the point of maximum impulse or PMI, location thereof, and many babies, upwards of 85%, have a murmur. We are going to talk about in cardiac, we're going to do what? We're going to do pathological murmurs, and we're going to do those that are functional. Now the abdomen, most of the time, a normal abdominal area on a newborn should not be flat. Flat means if you got a real flat, if not concave, you should be having a red flag raised in your mind thinking, are all the organs present? Are they shifted to one area or the other? Usually little abdomens on newborns are just a little tiny protuberant, just a touch, okay? You're going to count the number of vessels in the umbilical cord, 2 arteries and 1 vein. Check for hernias and anal patency. Often we'll look for the passage of meconium for anal patency. The genitourinary area, think about the male penis. You're going to inspect it. If you retract the foreskin, don't leave it retracted because you can cause swelling. Note the presence of testes. Testes descend in the 3rd trimester. Therefore, preemies are often going to have undescended testicles, or a term called cryptorchidism. Do you remember that term? And don't get too worried about that word because we're going to see it again in GU, okay? But that's what that means, cryptorchidism. But I will tell you, children that have undescended testicles for a period of time are much more at risk for testicular cancer. It's upwards of 38 to 50%. It's pretty high. So female genitalia, think about any type of bleeding. The labia minora and majora also will be more prevalent, prominent. Here is a structural consideration. You think about hypospadias. Hypospadias means the ventral surface, the underside of the penis is where the opening of the urethra is located. Now, a baby that would have either epispadias, which is on the top, on the dorsal side versus the ventral side, all they're going to do is offset having what? Circumcision, because when the baby is ready to do, they want to do a reconstruction, they'll use the tissue from circumcision to reconstruct the area. So they'll just be a little delayed. Now, you're going to look at the musculoskeletal system. You look at the spine, and you can see all kinds of things with a newborn spine. Whether or not they have scoliosis, which is lateral curvature, kyphosis, which is up in the, thoracic region, lordosis, which is going to be down in the lumbar region, spinal defects such as anything like a spina bifida. And you know, do you remember the term spina bifida cystica, the cyst, the cystic, the very large sac? Versus if you saw the term spina bifida occulta, hidden, that would be like a tuft of hair or a sinus tract along the axis. So you can see very mild to very severe, very obvious. And clavicle fracture we already talked about. Count those fingers and toes and creases and look for hip dysplasia. Let me tell you, they love hip dysplasia. Pink pig, got to get my pig. Let's talk about hip dysplasia. Actually, the hip dysplasia, as it says here, what is classic with hip dysplasia? Good old Ortolani's click is a click that's heard or felt, and the Barlow's maneuver. Barlow's maneuver is a shifting or a reassignment of the, do you remember what it is? It's the greater trochanter attached to the acetabulum. Do you all know, remember your anatomy and physiology, all those features? Let me put this down for a second and just have you think about it. If you as the examiner have your hands over the baby that's lying down supine, over the greater trochanter and the hip area, and you go and you ab away, duct, not add, but when you abduct, what you're doing is you're feeling for a slippage, you're hearing for a click. If it's very lax, you may not feel a lot of it. So you want to think about did you shift that bony prominence, which is the trochanter, back into the acetabulum? That's the Barlow's maneuver. But guess what else you're looking for? When you bring those little legs up and the knees, you're looking at knee height. And when we do musculoskeletal, knee height is called Galeazzi's sign. Don't even worry about writing it down unless you wanted to, because it's in the musculoskeletal chapter. But you're looking at knee height. If you have unilateral hip dysplasia, one is out of the joint, you're going to see a discrepancy in the knee height. You also, if you have unilateral, when you pick the baby up and look behind the legs for what? Skin fold thickness. The leg that is out of the joint is going to have more skin folds, right? Because it's out of the joint and squinched up. You also may have, doesn't it make sense, leg length discrepancy. Doesn't that all make sense to you? So you look at several things here. But I can assure you, they love hip dysplasia. There you guys go. Now, in third world countries, mothers carry their babies on their hips. And in that position, the baby's position of the legs are what? In abduction. So there you go right there. What is the answer of the treatment for babies that have hip dysplasia? Put them in a position of abduction. In our country, usually we put them in some type of a harness called a Pavlik harness, or you may see surgery may be needed. But that's basically, so right there, any type of a choice of answer that says abduction, that's the key, all righty? So you guys are going to do uptown right there. You got that, okay? So let's think about this. Newborn assessment, selective screening tests. You are going to be in the position to order screening tests. And because we've mapped out the human genome by, it's completely mapped out, the last screening test that they came up with was what? Cystic fibrosis. Did y'all know that? It's a little trivia question for you. Oh, before I go on, can I mention one other term with dislocated hip dysplasia? If you ever see the word luxation or subluxation, that's another term that I've heard has been used. So again, don't let terms intimidate you. But now let's go back to the screening principles for newborn screening. Disorders where symptoms would not be clinically present until irreversible damage occurs, such as hypothyroidism. Disorders for which there's a cure. What's a cure? Which one would be where there's a cure? If you had a kid with PKU, you knew that they could not tolerate phenylalanine, which I'm going to talk about. You take it out of their diet, they thrive, they're fine. See how simple that is. Disease where there's a particular prevalence in the population. Well, right there is like sickle cell. We talked about it being 1 in 400. Screenings of low false, positive, false, negative ratio, and high benefit to cost ratio. You know what? It's so simple to do a heel stick, get it on that special paper, and you know how they do it today? The reason why they can do so many tests for so many different newborn screens, they send it through, just as just a sidebar. You don't need to be tested on this, but I just want you to understand it. It goes through a mass tandem, like a bicycle that has multiple seats, mass tandem spectrometer. So when it goes through there, it picks up positive hits if there's something that looks unusual. If there is a positive screen, they go back and do a confirmatory test. Does everybody realize that these tests are not done in certain regular labs? They're done in what's called reference labs through your state public health system. So that's what it is. It takes specialized testing. I'm very proud to say in Florida, we are the one state in the nation that tests for the most newborn screens. We test for every type of heel stick, 35 tests are run. You do not need to know, there's over 50 conditions. You don't need to know, you only need to know a few because you're taking a what? National exam. Those of you who are in practice, what I would advise you to do is to call and find out from your state health department. Everybody has a newborn screening department with their public health system, and ask them, what is your state required to do? You see what I'm saying? So that's going to be very state specific. Now, when we think about this, there's always a mechanism for follow-up. Again, it's test over 50 conditions. The goal, originally, these started out with checking for metabolic disorders like PKU, and it's been expanded. You know what I'm saying? So over 50, all 50 states require, these are the ones you need to know. Pink pig, right here. PKU, galactosemia, sickle cell, and congenital hypothyroidism. So there's 4 that you need to know. Not everybody tests for like thalassemia and so forth, but your state may, and that would be up to you to do further study for that. Considerations for newborn screening. You need to rescreen mandatorily anybody that has been screened, any newborn that's been screened prior to being 24 hours of age. The reason for that is a lot of these have a metabolic component. You need 24 hours to see how the protein is broken down. One of those conditions would be PKU. Also, any baby that is symptomatic, you want to rescreen. Okay? Now, when we think about screening considerations, I'm going to go into the ones that we need to know, but I want you to think about some of the sensory conditions that we screen for anyways. Don't we screen for hearing in the hospital? Absolutely. What do we do in the hospital? What do you think about? What is the test called? It's called the Bayer test, the Brain Auditory Evoked System test. Do you remember that one? So we do know that that's going to be something that we're going to think about is covering, making sure that babies have all their sensory. And then vision, what type of a neonate, what condition would you think would be important for a visual exam? Any baby, and I don't mean in the newborn period because they can't respond to you, but you want to keep in mind a visual assessment. Babies that have congenital heart defects that maybe get oxygen, hyperoxygenation does affect visual development. So you want to think about that. So congenital cyanotic disease, and of course anything that's structural. So as we think about, on the hearing screening, you'll see there in B in your notes, the brainstem auditory evoked response test. Typically that is done before the baby leaves the hospital, and if they've already left the hospital, they need to come back to your office and be arranged to have that testing done. So let's look at some of the inborn errors of metabolism, good old PKU. In your notes there, you'll see 1 in 10,000 to 25,000. Please let me just assure you this. Do not feel like you have to memorize these occurrence or prevalence rates because you'll forget that. But you can see here it's not very prevalent, right? So that's mainly what that's for. But if you have a baby that develops PKU, which we know we can pick up very easily, and have you been reading certain, like when you go to get cough syrups and buy certain over-the-counter medications, have you noticed on the back of the boxes it'll say phenylalanine free? That's a protein that cannot be broken down easily. So we know that if a baby's positive for PKU, they shouldn't have anything that has phenylalanine. But if they don't get identified, they end up with developmental delay, severe retardation, seizures, aggression, and hyperactivity. We think about galactosemia. Now, galactosemia is liver dysfunction, coagulopathies. We think about, oops, let me see, I didn't mean to hit that. Galactosemia is more of that, you've heard of that maple sugar smell to the urine. You've heard that. That's very, very classic. But these individuals oftentimes will look septic. So remember we said if you have a baby that has a change in behavior or becomes symptomatic, that would be one that you would be concerned with. Then you've got your hemoglobinopathies like sickle cell, and we mentioned 1 in 400, and it can cause anemia and sepsis. We also know endocrine disorders such as hypothyroidism, and hypothyroidism is not real common. I normally think of it, it says occurrence rate 3,600 to 5,000. I usually think about 1 in 4,000 is really about the range. And so mental retardation, neurological abnormalities, we think about metabolic abnormalities. These are babies that can show no problem at all, but what's happening is their brain is being destroyed. So that's one of the ones that I think hypothyroidism, pink pig, would probably be one of the more prominent ones that they would like you to know about. Now, there are other disorders, and like I said, this is like skin. We could spend 2 weeks on all the different conditions, but you've got rubella, CMV, and herpes. These are all also available. And what is probably important for you just to know for your practice is that what is common, rubella we know usually affects the cardiovascular ophthalmic complications. CMV, I always think about a baby that's been exposed to CMV as having a small head and hearing problems. That's real common. And herpes, it affects skin, mouth, CNS, pulmonary effects. And we think about syphilis, congenital syphilis. Most all of your systems, your liver, your kidneys, your heart, and so forth. And good old cystic fibrosis is another one of those that's multi-system. So just kind of be in mind with those different ones. We are going to talk about syphilis later on when we do GYN. And CMV, just as a little sidebar, a lot of children that are immunosuppressed, like with HIV exposure, you think about things like, CMV and syphilis and so forth, so you may see some of those findings.